Hi everyone and welcome. More Good Days would like to acknowledge the traditional custodians of country across Australia and their deep ongoing connection to land, water and culture and community. We pay our respect to elders past and present and to all Aboriginal and Torres Strait Islander peoples today. Welcome everyone to this More Good Chats. I keep getting that wrong. More Good Chats live. We're talking back surgery today, risks, realities and alternatives with Professor and Orthopaedic surgeon Ian Harris, who I'll introduce in a moment. But just for those of you who don't know me, I'm Mandy. I'm one of the mindfulness and pain recovery coaches here at More Good Days. By being here today, you agree to our participation guidelines for this live session. It's being recorded, so we just ask that you be respectful, stay muted throughout the talk. If there's time for some Q&A, we'll get to that. You're welcome to put that into the chat. Just want to start also by just acknowledging that the back surgery is a huge decision, and some of the information we share today might even challenge some long-held beliefs, so that can be upsetting or unsettling for people, and just kind of calling that out, that's okay. I myself have sat in that seat for twice in my 3-decade journey with back pain, so I know how complicated and confusing and challenging it can be. So with all of that in mind, today our goal is really just some information so that you can walk away feeling like a bit more empowered and maybe confident in whatever decision you make. We know that there's about 25%, like about a fifth of the people that are currently doing our program say that they are willing to have spinal surgery in the next 5 years. And about 30% more of those people are unsure whether they'll do it. So we really want to dig into these, the evidence for it, the risks and the alternatives. So it is my very great pleasure to introduce you to our guest today, Professor Ian Harris. Ian's an orthopaedic surgeon, a leading researcher. His studies look at the results of surgery from really large data sets. He's been looking into things like who benefits from surgery, who doesn't, how satisfied people are afterwards, and how strong the research behind surgery actually is. He's published very widely in evidence-based medicine and is really passionate about helping people be informed in their decisions. So we're really grateful to have you with us today, Ian. Thank you so much. It'd be great to start off to maybe if you could just walk us through a little bit of your history, your background as an orthopaedic surgeon. And I'm really curious if there was a moment where you sort of changed perhaps your view of back surgery.
Yeah, that's a good question. So I'm an orthopaedic surgeon trained in Australia, like most orthopaedic surgeons here, and I've been doing it now for a very long time. But yes, when I started practice, I would consider myself to be just the average orthopaedic surgeon, and I also did spine surgery as well as other types of orthopaedic surgery. Including spine fusions for back problems, spine decompressions, neck and back, and trauma as well, people with spinal injuries. And I did many other operations as well. And the reason I did all those operations is because that's what everyone was doing. And that's often the reason why many surgeons practice today, because that's what they were taught and that's what their mentor did and that's what those around them do. So they do the same thing. And it wasn't really very science-based. I always wanted to be a good scientist and I wanted an academic career, but I didn't take my academic detour until after I'd been in practice for 7 years or so. And that's when I started studying evidence-based medicine, and I realized that there wasn't very good evidence for a lot of what we did. And when I looked at the evidence that was there, it was a little bit wanting. And that really changed what I did. So a lot of operations that I was doing regularly, I basically stopped doing. And since then, I've been trying to generate more evidence on whether things we do in orthopedic surgery actually work or not, rather than whether we think they work, which is normally what we base our decision making on.
Yeah, and so great. We love evidence-based medicine here. And you've mentioned already a couple of different types of surgery, but it might be just helpful to touch on, I suppose, some of the different types of back surgery that people might consider.
Yeah, back surgery is pretty broad. That would include neck surgery as well as lower back surgery. You can operate on the bit in between, which is the chest or the thoracic spine, but that's much less common. And so spine surgery is usually either neck or lower back or lumbar. And when you're doing spine surgery, you can divide spine surgery up into another two groups based on whether you're doing decompression surgery or fusion surgery. Decompression surgery targets the nerves. So even though you may be operating on the bones or the ligaments around the spinal cord or the nerve roots, it's the nerves that you're trying to treat. So if somebody, I guess the classic example is an acute disc prolapse, where the disc in between two vertebrae can squeeze out and press on the nerves, which can cause quite terrible leg pain. And so that would be treated with a decompression operation. And that involves going in there and removing the disc material or any bone spurs or thickened ligaments, for example, that might be causing pressure on the nerves. And that could be in the neck or the back. It doesn't have to be a ruptured disc. I just gave that as an example. But whenever there's compression on nerves, then the surgery is normally decompression. Now, spine fusion is different. That's where you fuse two vertebrae together. And I guess an offshoot of that, because it's done for similar reasons, is disc replacement surgery, where instead of fusing two vertebrae together, the disc between the two vertebrae is removed. And instead of just putting bone in there to fuse them together, they put a disc replacement in there, which theoretically, allows a little bit of movement, so you're not really fusing the two together. And that's a more recent addition, but it's often done for the same reasons as fusion.
And
so
these
surgeries. Yeah, so I was just going to say, so neck and lower back is one way of looking at it, and decompression versus fusion. And they can be combined. Like a patient may have a decompression and a fusion, but they're the two broad types of spine surgery that are done electively.
And there are many of the ones that people that come to our program are considering. So, these spinal fusions and replacements and decompressions have been done now for many years. So, I imagine we're starting to gather some good evidence on outcomes. Can you maybe tell us some of the best research that's currently around in terms of the effectiveness of these surgeries, particularly for long-term pain and function outcomes?
Unfortunately, we're not gathering a lot of evidence on how effective these operations are. And that's for many reasons. One of the reasons is because surgeons don't have to. And they can operate on people based on their perception of the effectiveness, not on any hard data that's effective. And not many people are gathering that evidence. And it's been a long time since the last proper scientific comparative clinical trial or a randomized trial has been done comparing, say, spine fusion to non-operative treatment. So there were a handful done over 20 years ago. The summary of those handful of studies showed that the fusion is not better than a structured non-operative program, such as one involving cognitive behavioral therapy, and or a structured exercise program. And there hasn't been much evidence regarding spine fusion since then. There is a study that is currently underway in early stages in both the UK and Australia, which is comparing spine fusion to best non-operative care for people with low back pain. And the results of that study won't be available for some years, but at least they're gathering more evidence. Regarding decompression, there have been some very good studies looking at one of the common reasons for decompression, which is a disc prolapse in the lumbar spine. And those studies show fairly clearly that if you operate to remove the disc or the thing that is pressing on the nerve, if a patient has a lot of pain in the leg, then they will get relief from that pain, and they will get relief fairly quickly. However, there is no difference between operating on it and leaving it alone in the longer term. So at 1 year, 2 years, or longer, the chance of the patient having their pain resolved is the same, whether they have surgery or not. And that's because when a disc prolapses, it's quite large and it can take up a lot of space and it can squash the nerve. But once it's prolapsed, it gradually shrinks and reabsorbs. So over time, the pressure goes and the pain goes. So people who have surgery can get that relief quicker, but in the long term, it doesn't make any difference. So the decision-making for decompression surgery in that more acute disc prolapse situation normally depends on how well the patient is coping with the acute pain and what their feeling is towards surgery. So the surgeon may have a discussion with them, and if the patient's just not coping at all, in terrible pain, and really doesn't want to put up with it any longer, then the surgery is a reasonable option to get them better quicker. But if the patient says no, it's at its worst, I think I might be getting better, and I'm happy to continue with it, knowing that it will get better eventually on its own, and that patient is probably better off without surgery, because over time their pain will resolve anyway. Other types of sorry to interrupt. Yeah, so other types of decompression surgery don't have as much good evidence. Another common reason for decompression surgery is in older patients who have spinal canal stenosis, which is associated with aging, and that's a general narrowing of the spinal canal in the lumbar spine. So it often affects people over 70, over 80. And that's commonly treated with decompression, but it's not so clear that decompression is better than not decompressing, because sometimes people get better anyway. Sometimes they get better after surgery, but then after 12 months, the symptoms come back again. And so it's not that clear. So we're doing a study at the moment where we're comparing surgery to not doing surgery, and hopefully the results of that will be out in the next 2 years or so.
I look forward to hearing the results of those surgeries. And yeah, I mean, I'm actually quite surprised from what I'm hearing from you. It sounds as though even though these surgeries happen a lot, the actual evidence of the success rates of them or the outcomes for them is surprisingly poor. Would that be?
Yeah, well, about half of what we do in orthopaedic surgery has been subjected to a randomized trial comparing doing it to not doing it. And that's not unusual, that 50% figure with other specialties as well. So a lot of what we do doesn't have a very good evidence base. That doesn't mean it's not effective. It just means we don't know if it's effective or not. But in spine surgery, there are studies, and some of those studies, particularly for spine fusion, are not favourable, and yet we're still doing it. And one of the reasons we know that there's problems with doing this operation is because of the practice variation. So if you look at the variation in, say, knee replacement surgery or hip replacement surgery, which is a very common operation for painful hips and knees, it's pretty evenly done throughout Australia and throughout the world. So if you look at the rates in America, they're a little bit higher than the rates in the UK, which are a little bit lower than the rates in Germany, but it doesn't vary that much. And if you look across Australia, the rates of hip and knee replacement are pretty consistent between states, and they're pretty consistent between private and public sectors. Spine fusion is a very different story. And if you look at the rates internationally and even within Australia, there's huge variation where the rates, for example, are very high in the United States and very low in countries where they're not paid to do the procedure, such as the UK. And in Australia, there's a vast difference in the rate of spine fusion surgery between the private and public sectors, where it's rarely done electively in the public sector. And it's increasing at quite a steep rate and has been for about 20 years in the private sector.
And that variability between practice when it comes to surgery, what's kind of behind that? What's the reason we're seeing that?
When you see variation, you have to check that it is what we call unwarranted clinical variation. So, for example, if private patients are more likely to get back conditions that need fusion surgery, then that would explain it, but they aren't. So this is what I would call unwarranted clinical variation. And when you see unwarranted clinical variation, it tells you that somebody's wrong. So either private patients are getting too many fusions, or public patients are getting too few, or both. But it means that somebody's wrong when you see rates like that. Or if you see very high rates in one country and very low rates in another country that has a similar population and a similar demographic, there's a problem as well. That means one of those countries is wrong, or both of them are wrong. But somehow we haven't got it right.
And yeah, which is why, you know, more research that you're looking into is going to be so critical in the future as well. So I suppose, you know, shifting a little bit here in terms of, you know, I suppose the topic, how people come to these surgeries, often, you know, people will be basing the decisions on perhaps some imaging that they might have had. And so, yeah, would you be able to speak a little bit about the role of scans in all this and how helpful / unhelpful they might be in informing the decision?
Yes, it's a two-edged sword, because imaging can be very helpful and it can be very misleading. So I'll give you two examples. If you think somebody has a ruptured disc where they were bending over or picking something up and they got sudden pain shooting down the back of their right leg, and they've got numbness in the distribution of a certain nerve root, then clinically you can pretty much pick that that patient's had an acute prolapse of their, say, L5-S1 disc, something like that. And imaging will confirm that. And because you can't see it on an X-ray, but an MRI or even a CT will show that disc very clearly. It'll show where it is, what nerve root it's pressing on, and if you decide to have, well, then that helps you with your decision making because you've got the diagnosis. And if you do decide to have surgery, that imaging helps you because it tells you where to do the surgery. You know exactly what level it is and what to expect, how big it is. So imaging can be very helpful. Back pain is another story altogether, where imaging can be quite harmful. So people with non-specific low back pain. So this is not nerve root irritation. This is low back pain, typical low back pain that, you know, a very large proportion of people get. And without any specific sort of red flags or obvious cause for the back pain, there's very little that can be done. Imaging does not help. So most clinical practice guidelines recommend against imaging for non-specific low back pain. The reason is because anybody, and most people are, you know, middle-aged or older, every single person who has an MRI scan will get a one-page report listing all of the abnormal findings on that scan. And that's people with back pain and without back pain. And there's very poor correlation between the, you know, degenerative changes that you see in the lower lumbar spine and back pain, because nearly everybody has those changes. And there's this mistake we make when we're seeing patients, where if we see a patient with pain and we see an image that shows something, we assume that that's something on the imaging is causing the pain, and that's often not the case. And that's why it becomes very misleading. There was a great study done in the US looking at this, where they looked at patients who presented for primary care to a GP clinic with back pain. And they randomized the patients to receiving either a plain X-ray or an MRI scan. And then after that, they didn't dictate anything that happened to the patient. It was up to the clinician to decide what to do. But the imaging that the patient had at the time initially was either a plain X-ray or an MRI scan. Now, clearly the MRI scan is going to show you more things than a plain X-ray. X-ray is often not very helpful, but it can show arthritis or some degenerative changes. And they followed the patients for a year or two. And what they found is there was no difference in the degree of back pain that people had after 12 months in either group, whether they had an X-ray or an MRI scan. So the people weren't any better off. There was a significant difference, though, in the number in each group that had surgery. So if you had an MRI scan, you were more likely to have surgery. And that's because it shows things. And then that worries people. And then the patient thinks, I need to get that thing that I can see on the scan taken out, because that's my pain. I can see that black spot on the imaging represents my pain. And when that gets removed from my body, the pain will be removed. Very simplistic and very attractive, very appealing, but wrong most of the time.
Yeah, and it certainly is attractive and appealing, because you sort of think, if that is right there, that thing that I can see, and not the things that you can't see, which scans don't show, your sleep and your stress and all the other sort of contextual things that can play a role in pain as well. There was also another study that sent people off to get 10 different MRIs, and I think none of the reports completely agreed as well. So,
yep.
There's possibly a degree of confliction in terms of interpretation.
Yes, there's a movement that I agree with that suggests that MRI reports should say no changes beyond normal age-related changes, full stop.
Yeah.
That there's no other pathology there.
Yeah, I love that. I love that Dr. Sarno talks about normal abnormalities, or even in our program we talk about wrinkles on the inside. These are the things that we just kind of expect to be there.
That's what we're seeing.
Yeah,
that's what we're seeing. Yeah.
So if people are considering back surgery, obviously there's maybe some risks they should be made aware of. Can you maybe outline some of those?
Yes, there's significant risks with back surgery, even though a lot of back surgery is being done less invasively. So, with smaller incisions, particularly decompressions. There are risks, of course, because you're operating very close to the nerves in the spine, also blood vessels. Every surgery has a risk of infection. The risks are there, whether it's a decompression or fusion. The risks of fusion are a little higher because of two things. One is it's a bigger operation. So to cut away bone, even if you're putting in a disc replacement or whether you're fusing it, you're putting screws in, you're putting metal in, you're sawing the bone, you're losing more blood. It's a longer operation. It's more invasive. It's a bigger incision. And so fusion has greater risks. It also has greater risks because it's often done inappropriately. So it's done on people with back pain where it is not going to help them. And that's why we see very high revision rates for spine surgery. So when we're talking about other common operations like hip replacement and knee replacement, we don't expect to go back in and operate on those patients again, not in the near future. Now, the probability of having problems increases with time, so that if they've had a hip or knee replacement in for 20 years, maybe it's going to show some problems. And certainly we do operate on them, but it's something we try to avoid. But the risk of needing another operation on your spine is much, much higher. And it depends on the exact setting, but it's commonly reported after spine fusion that the risk of revision in or needing another procedure within 2 years is upwards of around 20%. And that normally means that we got it wrong the first time. And fusion can lead to problems at other levels of the spine, and the fusion needs to be extended. The bone can not fuse and cause problems. There's complications from the implants. The implants can migrate and break. Disc replacements can come loose. So there's lots of things that can and do go wrong. But this is not just a technical issue. A lot of people think, oh, that's because it's complicated and there's all these parts, and I guess the parts can wear or break. That's not normally what it is. And so, to give you an example, I was asked yesterday to give a medico-legal opinion on a patient who has had countless spine operations, and this is a patient who had a problem with chronic pain. They didn't have something in their back that needed to be removed. And in fact, this patient saw several doctors that I know, quite sensible spine surgeons, who said this patient should not have spine surgery. There's no reason to do spine surgery for this patient. But this patient went and saw other doctors, and eventually, of course, you'll see someone who recommends surgery. And so this patient had a disc replacement at one level, a disc replacement at another level. The disc replacements were removed and the spine was fused. The spine fusion caused complications and needed to be refused, and the pain persisted, so they had to fuse other levels. The pain persisted, so they fused the sacroiliac joints. They used a drug in that which caused some complications, which led to further surgery. The patient is now suing the doctors. They've still got terrible pain, and they've gone through this journey for years and years and years. For somebody who probably, so it wasn't a technical issue with the equipment or even the technical ability of the surgeon, or it wasn't one of those things like infection. Infection is one of those things. You can never reduce the risk of infection to 0%. There's always going to be patients who will get an infection, which is a terrible complication. So it's not one of those things. It's a problem where people were trying to treat chronic pain with an operation that is not effective for chronic pain.
Yeah, it's a really, horrific story and example that you've given there, and it sounds like it's not just the risk of the surgery itself; it's the potential follow-on effects and impacts that come after that as well. I mean, is it for the people listening, obviously, that are contemplating this, is there something that you think that it's really important to understand in terms of before they make this choice?
Yes, there is. And there's one thing we say, so this is not just related to spine surgery, but often we have difficult decisions where a patient has a certain condition and we think, I'm not sure if surgery is the right thing for this patient or not, or whether we should leave it alone or we should wait longer. Often surgeons and patients think, well, why don't we just do it? Then we'll know. If I don't get better, great. I'm no worse off. But if it makes me better, then we've won. So if we don't know if surgery is going to work or not, why don't we just do it and find out? And take the chance. So that's a common way of thinking, and it's not a good way of thinking. There's a saying we have in surgery that there's no condition a patient can have that surgery can't make worse. So people could say, oh, but my pain's terrible, therefore you need to operate. And I would say to them, you think your pain is bad now, wait until you have spine fusion surgery and a complication from that, and need to have further surgery. You will be worse off than you are now.
It's such an important message to share, and I think that I was very fortunate in my experience when I went to see a spinal surgeon to consider further fusion of my spine. Actually, went that same approach, or the reverse approach, I suppose, was why don't you go and try stuff for yourself for another couple of years, and if it's still bad, come back and we'll talk, which actually gave me hope and also the confidence to continue with my own kind of pain management approaches. And yeah, I've managed to stay away from that surgeon's office for the next 20 years and, doing some of the things that we talk about in the program. So, yeah, I mean, it's providing such information here. I'm sure everyone's really, loving that. And I suppose for people that maybe are considering it and they're now listening to you and having doubts, it can sometimes feel like you've explained that surgery is like the last hope. Like you just, you're at your wit's end, you've tried everything and the pain remains, you're confused, you're not sure what's going to happen. All you really want is for the pain to go away. I've been in that exact position. If surgery isn't your option, what advice do you have for people that are, what's the alternative, I suppose?
Yeah, so a lot of people, when it comes to considering surgery, have tried a lot of non-operative treatments, and that makes surgery appealing. And there's another justification for surgery that I disagree with, is that, well, if non-operative treatment has failed, then operative treatment is indicated. That is true for some conditions. So for osteoarthritis of the knee, if a patient has tried all the non-operative treatments and they're still getting terrible pain, then surgery may be justified. But with back pain and fusion, that's an operation that doesn't work. The failure of other treatments doesn't suddenly make it work. It still doesn't work. So it shouldn't be done for back pain, in my opinion. The problem is that patients may go and see two different doctors, and one doctor will say, no, you shouldn't have the back fusion because it doesn't work and it's not very effective and there's no evidence for it. And then they'll see another surgeon that says, well, 2/3 of the patients get better after back fusion. And I don't know whether you're one of those 2/3 or not, but pretty good odds, why don't we give it a go and we'll see. And that's largely what surgeons say to their private patients. It isn't what they say to their public patients, which is why this is done in the private sector and not in the public sector. And as for the alternatives, that's not my area of expertise, but there are effective, in fact, this whole program of All Good Days is one example of such. So there are effective ways of doing it, but I just caution people against thinking that just because they've tried a non-operative treatment and it hasn't worked, it doesn't mean that surgery will work. And I should qualify that 2/3 improvement, by the way. So in studies that have been done, most studies, it could be arthroscopy of the knee or spine fusion or decompression of the shoulder. These are operations that don't work, have been shown clearly in studies that they don't work. Most patients, often about 2/3 of patients, get better after the surgery. But the same proportion of patients get better after not having the surgery in what we call the control group in those studies. So we haven't done placebo studies of spine surgery, but we have done placebo studies of shoulder surgery and knee surgery, arthroscopic surgery, where half of the patients got the real procedure done and half of the patients got a sham or placebo and nothing done to them. But the patients were asleep, and when they woke up, they didn't know what they had done. In those studies, about 2/3 of the patients got better, or a lot of the patients improved to a certain degree in both groups. They just improved the same. So if I wanted to sell you spine fusion surgery, I would say, well, all the studies that have been done so far show that 2/3 of the patients show significant improvement after surgery. You're going to think, well, sounds pretty good to me. I think I'll try it. Whereas I would say, all of the studies done so far show that the probability of you getting better is no different whether you have surgery or don't have surgery, which is the same figures, but that's putting it to me in a more honest way.
And some of those risks that you talked about don't exist with the non-surgical route.
Yeah, and
as
a
well.
lot of studies that compare surgery to non-operative treatment, if they don't show a difference in the clinical outcome for the patient, whether that be pain or function or whatever, they often show an increase in the risks of harm because surgery is much more invasive than not operating. Yeah, that's the case for a lot of surgical versus non-surgical studies.
Oh, it's a lot for people to take in, so I might just pause here and just have a quick check-in on whether there's any questions in the chat. I know it's very hard, I suppose, for Ian to speak to specific people's, situations without like knowing the context. I hope that what we've already discussed gives a lot of food for thought. There is a question in here, Ian, if you're happy to answer it, around, if an MRI can give us anything really obvious and specific to sort of point to, I suppose, in terms of evidence for whether, surgery is necessary.
I don't think so for spine fusion. It does give us very good information about the nerves in the back and whether they are under pressure or being compressed, or whether a disc is prolapsed, for example. But sometimes, for example, fusion is done when one vertebra slips forward on another. It becomes, I hate to use the word unstable because it doesn't have a very good definition, but there's a certain condition where spine fusion is thought to be effective. It's by no means the main reason for back pain, but it is sometimes seen. And it's used as justification for spine fusion surgery, but it's very obvious on a plain X-ray. MRI doesn't add a lot to that. Nearly everybody these days will get an MRI, but to me, people with back pain, and overall, an MRI is more harmful than helpful. Unless you suspect a rare condition, like if you think somebody's got an abscess or an infection in their back, which are like super, super rare, or a tumor or secondary cancer from breast cancer seeding to the back, things like these can happen, and MRI can be very helpful. But for the patient without those conditions who just has chronic back pain, it's not helpful.
And I think you've already mentioned it's part of the clinical guidelines that unless those red flags are present, is that right? That it's not really recommended that they have
It's
imaging.
not recommended. Yeah. It sounds bad because an MRI gives you more information than an X-ray, and it doesn't make sense that having more information is somehow harmful. Like, how can that be harmful? Well, on its face, it isn't. It's what we do with that more information. So when I see someone come in and they've had an MRI of their back, I can see I get lots more information, but I know what information is important and what isn't, and I know what to dismiss. The trouble is not everybody does that, and the temptation is to look at one of the lines, the annular tear. These are some of the words that they use in MRI scans that you just see all the time, and to think, oh, it's torn, something's torn, therefore I need to repair it. And it's the language that we use as well. The language we use is a big problem. It's a problem elsewhere in the body when people have a rotator cuff tear in their shoulder or a meniscal tear in their knee, they think they need to have that tear repaired. Because if you have a tear in your jeans and you sew it together, then that works. Why would you not repair it? And I have to explain to patients, it's not like a tear in your jeans. It's more like a pair of jeans that you've been wearing for 20 years and the knees have just worn out and they're threadbare. Now, you can call that a tear because there's a hole in your knee, but stitching it won't do any good. It'll just tear it more. There's nothing there to repair. So the language of these reports is one of the problems as well.
Yeah, they can be really frightening as a patient to read it, which sometimes we get given them, and and then you start really focusing on them, and we know how much fear plays a role in the whole complex experience of pain. So I'm just conscious of your time, Ian, so I might just I know there's a few specific questions there, but maybe I suppose we could just quickly, if you're happy to touch on, in your experience, what questions maybe someone considering surgery might be asking, their clinicians or their surgeon in terms of checking whether it's going to be right for them, because maybe they've heard all this information and they've got an appointment coming up. What are some questions you'd recommend that they take back to their medical team?
So just in general, there's a few pieces of advice I give patients. First of all, don't feel bad about getting a second opinion. Doctors don't mind. A lot of patients think that means that they don't trust the doctor, or they're worried about the relationship with the doctor if they go and get a second opinion. Doctors don't mind. We encourage people to get a second opinion, because if you get 2 or 3 opinions and everybody's saying the same thing, that helps you. That reinforces it. And if you're a bit suspicious of the first opinion and the second one is contrary, then that gives you a bit more information. But when you're going to see a doctor, the question I ask, if anybody offers surgery, and this goes across the board, whether it's your hip replacement or your back fusion or your spinal decompression, is to ask the patient, what is the relative risk of that's a technological term, but sorry, what is the probability of me getting better if I have surgery compared to if I don't have surgery? That's the most important thing, because you're making a decision not to have, it's not a decision whether to have surgery, it's a decision on whether or not to have surgery. So you're making a decision between 2 different things, and you need to be able to compare those 2 different possible outcomes of your decision. So if you just say, well, tell me what will happen to me if I have surgery, the surgeon will say, well, most likely you'll get better afterwards. But if you say, what is the relative, or what is the probability, comparative probability of me getting better with surgery compared to not having surgery? And then they may be forced to say, well, the studies show that there isn't actually much difference. And then you can ask the follow-up question is, what is the probability of me being harmed with surgery compared to not having surgery? And that's what you've got to weigh up. Basically, every decision to have surgery or not is a balance of the relative risks and benefits, or harms and gains, pros and cons.
Yeah, they're really great suggestions there in terms of questions to ask. Thank you for those. Before we wrap up, Ian, anything you really wanted to say that we haven't got to yet, or any messages for the people listening here in terms of things that you want them to go away with knowing?
Not that I can think. I think you've covered it very well. I guess the other thing I like to say is there's a certain status that doctors have. Amongst doctors, there's a certain status that surgeons have, and including spine surgeons and brain surgeons and neurosurgeons, in that they often aren't questioned, and they're often considered to be the definitive final answer. So if the patient's physio says, I'm not sure if spine surgery is a good idea for you, I think we should persist, or we should try something different, I don't think it's a good idea, the patients tend to think, well, what would you know? My neurosurgeon said that I need surgery, so that's the end of the argument. It actually isn't like that. Doctors are very, very fallible, and a lot of them are very bad scientists, because they don't look at the balance between the risks of surgery versus no surgery. They just know that a lot of their patients get better, so they keep operating. And that's not very good science. I just saw a question pop up, which is another good one. What is the role of cortisone injections? The answer to that is that they don't work. And that's very clear. And there's very high quality international guidelines recommending against them. In fact, they withdrew funding from them in the UK, and yet it is one of the most common medical procedures done in Australia, costing millions of dollars annually, with multiple patients having multiple interventional procedures. So we've just talked about spine surgery. We haven't covered spinal cord stimulators, radiofrequency ablation, cortisone injections, all of which do not offer benefit over not doing it. at best, if you were to be really biased and try to look at the evidence with the rosiest glasses you could, you might make an argument that they might make people better for a week or two. But the best evidence is that they don't provide any clinically meaningful benefit compared to pretending to do an injection or not doing an injection.
Well, thank you for that question, and thank you for that very, very honest answer in terms of, just being very clear that, this is what the evidence is.
Yeah, that's what the science is. If you go and ask a radiologist or a surgeon or someone treating your back pain, your GP or whatever, what the evidence is or what the benefit is, they'll say, well, a lot of my patients like it. I had a patient last week who said it was really good. That doesn't mean it works.
It doesn't mean it'll work for you, because everyone's individual and there's lots of other things, that form part of the person's experience of pain as well, isn't there? So thank you so much, Ian, for your time. We really appreciate it. You've definitely given some enlightening information, hopefully, for people that are here and people that will be listening to this in the recording. I want to personally thank you for all the work that you do in this space in terms of getting this information out there to people that are making these really, really difficult decisions about surgery. If anyone listening is living with back pain and considering surgery and you want more support, obviously the More Good Days program is there, and we are happy for you to reach out to us. And just as we get ready to sort of close out this session, I suppose, just remembering to offer yourself a little bit of kindness as well. These are big decisions, just a bit of acknowledgement that living with back pain is very, very hard and challenging, and these decisions are not easy. So give yourself a lot of kindness after taking in all this information. We're here if you want extra support or to chat through things, as well as your clinicians. So thank you so much, Ian, and to everyone that's been here for this really enlightening session. I hope everyone has an enjoyable rest of their day. Thanks so much.
Thanks very much.
Bye for now. Thanks, everyone.
Bye.
Thanks, Mandy. Thanks, Ian.
Okay.
Oh, I've got to stop the recording.